Today we'll be talking about cervical cancer, and more specifically cervical cancer that is caused by the HPV virus. Cervical cancer is a disease of the woman's cervix. In healthy cells, cell division can and should stop when these cells do not need to divide anymore. Cancer cells, on the other hand, lose their ability to regulate and control their own processes and spiral into an abnormal state in which the cells can start to form a mass called a tumor. Initially, these abnormal cells are not yet considered precancerous. However, given enough time, without treatment, these cells can eventually turn into cancer cells. The main risk factor for cervical cancer is the infection of the cervix due to the human papillomavirus, also known as HPV. In a study conducted at the Department of Pathology, Amsterdam, Netherlands, there are over 100 different types of HPV, with 38 of these causing infection of the anogenital tract. HPV is a DNA virus that contains a genome of about 8,000 base pairs. This viral DNA encodes for proteins that will later be released into the cell. Viral DNA will be incorporated into the host genome, where it will be able to reproduce and spread once the host cell replicates or expresses any genes in and around the viral DNA. There can also be a latency phase where the virus stays hidden within the cell. These proteins and integration of the viral DNA to the host genome will lead to these cells becoming abnormal and eventually lose control of their own regulation. There are two types of categories of HPV. There are the low risk and the high risk HPV. Low risk HPV is associated with symptoms like genital warts and epithelial lesions and can be treated. On the other hand, high risk HPV is associated with anogenital cancer. The HPV virus can infect the cells in the female reproductive system. Once it infects the cells on the surface layer epithelial of the cervix, it makes its way deeper into the keratinocytes, where, when left untreated, the infected cells can develop into masses that move up to the surface and further spread and grow into tumors that can cause cervical cancer. Most of HPV or low-risk infections caused by HPV are dealt with by the immune system. However, the HPV virus can invade and sneak past these cells. During the initial exposure, the host's innate immune system is the first to take action. The first line of defense consists of innate immune cells like dendritic cells, natural killer cells, natural killer T cells, macrophages, and neutrophils. The dendritic cells contain PRRs that bind to the HPV PAMPs, and these cells carry out phagocytosis. And dendritic cells also contain the endosomal TLRs. Next are the neutrophils, and these cells also carry out phagocytosis. The macrophages release interferon alpha and beta, and these have antiviral activity. These activate genes expressing antiviral proteins and increase expression of MHC class 1 and 2. Next, we have the NK cells. These are naturally activated when it recognizes any alterations in cellular MHC when the cell is infected or compromised. NK cells are not activated through TCRs, which make them more effective for viral infections. They kill infected cells through cytotoxic granules, which contain perforin and granzyme, which will induce lysis of the infected cell. Last, the NKT cells are a derivative of the T cell with a modified TCR. They help activate immune cells, such as NK and T cells, and they produce a large amount of cytokines for signaling. And one last thing, these modified TCRs recognize glycolipids. At early stage infection by HPV, these cells usually respond with a well enough immune attack to eliminate the virus by means of promoting a cytokine mediated pro-inflammatory process. The presence of cytokines in the blood is typically one of the earliest indications that the host has been infected with the virus. These cytokines are interferon alpha and interferon beta, TNF alpha, interleukin 6, IL-1, IL-12, and interferon gamma. When these cytokines enter the circulation, they elicit symptoms typical of many viral infections, including that of fevers, sleepiness, lethargy, muscle pain, loss of appetite, and nausea. In the event that HPV evades this innate immune response, it will promote an anti-inflammatory microenvironment. Evasion is the result of expression of their E6 and E7 proteins, among other viral proteins that HPV virus will encode for. Other viral evasion mechanisms are to include modulation of cytokines, chemoattractant expression, alteration of antigen presentation to the host immune cells, and the downregulation of the IFN pathways and adherence molecules.
HR-HPV, also known as high-risk HPV, consists of two main types of HPV, HPV 16 and 18, which accounts for 70% of cervical cancers in the United States. There are different stages leading up to cervical cancer. They are CIN1, CIN2, and CIN3. CIN stands for cervical intraepithelial neoplasia. These three stages of CINs are characterized by tumor immune tolerance. Tumor immune tolerance occurs when there is an impaired activation of CTL or cytotoxic T cells, decreased and suppressed LCs, which are Langerhans cells that belong to dendritic cell family, inactivated and immature DCs, which are dendritic cells, an accumulation of Treg cells, and an imbalance in T helper cell 1 and T helper cell 2. It is also characterized by TLR expression profile change and tumor suppressor gene inhibition. In CIN1, it is also where the virus will incorporate its genome into the host genome. And upon reactivation of the viral genome, it will disrupt the E2 function. When the viral genome becomes expressed with the host genome, the viral proteins E2, E5, E6, and E7 will also become expressed. As mentioned earlier, E2 expression will disrupt this function, where E2 will regulate the E6 and E7 oncoprotein function. The disruption of the E2 function causes an uncontrolled expression of E6 and E7. E6 and E7 oncoproteins binds to tumor suppressor protein P35 to arrest the cell cycle. E6 and E7 also causes downregulation of TLR9 expression, which is a viral DNA sensor, which is needed to activate APCs. E6 and E7 also reduces the expression of transporter-associated antigen processing 1, therefore blocking activation of T cells. E5 viral protein downregulates histocompatibility leukocyte antigen, or known as HLA, on expressed infected cells, which allows the virus to escape immunosurveillance. There are various of immune cells involved in the immune response to HPV infections. The first cell being keratinocytes. Keratinocytes are immune sentinels and are able to induce expression of Th1 and Th2 type cytokines, and also cytotoxic responses in the CD4 positive and CD8 positive memory T cells respectively. KCs function as an accessory cell for presentation of endogenous antigens. KCs also possess an endosomal TLR, which combats viral infections and recognition of viral nucleic acids. TLR activation promotes production of cytokines, creating a powerful pro-inflammatory environment. TLR9 activation in KCs make TNF-alpha, IL-8, CCL2, CCL20, CXCL9, and type 1 IFN. Another type of immune cell that helps combat HPV infection are natural killer cells. NK cells play a major role in combating both tumor and virally infected cells. IFN gamma, which is a TLR agonist, indirectly activates NK cells. This causes an induction of pro-inflammatory response through TLR and agonist, which rescues KCs from HPV-induced microenvironments to promote antigen presentation. NK cell with its HPV antigen promotes CD4 positive and CD8 positive T cells antigen-specific responses and rapid release of high amounts of inflammatory cytokines, or IFN gamma. The next immune cell that plays a major role is CD8 positive T cells, which are also known as CTL, or cytotoxic T cells. CTLs eliminates viral infections, secretes IFN gamma, and displays cytolytic effects mediated by molecules such as granzymes and porphyrin. CD8 T cells recognizes HPV antigen presented by KCs. In CIN lesions, they are antigen expressed and alpha 4b7 positive. Alpha 4b7 positive is an important integrin on T cell homing. Their presence in the epidermis was associated with vascular expression of the alpha 4b and MADCAM1, which is an adhesion molecule important in T cell homing. The next type of immune cell that is important for immune response is CD4 positive T cells. CD4 positive T cells secrete IFN gamma and mediates killing primarily by engagement with ligands for death receptors such as FAS or TRAIL, resulting in caspase-mediated apoptosis. This provides help by secreting interleukin-2 to ensure that CD8-positive T cells are effectively activated to carry out their cytolytic role. This also contributes to viral clearance in absence of CD8-positive T cells. It is also essential for reduction of viral burden following depletion of either CD4-positive or CD8-positive T cells created by the microenvironments by the HPV virus. T helper cells respond to E2 viral protein to regress LSIL, which is also known as low-grade squamous intraepithelial lesion. The symptoms of HPV is caused by the HPV microenvironments, which is the environment consisting of an increased Treg cell and decrease of the other mentioned immune cells. An increase in Treg cells causes an uncontrollable growth of that area, which results in tumors. These tumors can lead to irregular, heavy, or abnormal menstruation, fatigue, nausea, and weight loss.
There are many facts about cervical cancer. The most well-known about cervical cancer is that HPV is the most common cause of cervical cancer, since it causes the majority of cervical cancers and accounts for approximately 9 out of 10 cases. HPV is estimated to be the most common sexually transmitted infection in the United States. There are over 100 different types of HPV, most of which are considered low risk and do not cause cervical cancer. But HPV is found in about 99% of cervical cancers. Cervical cancer was once considered one of the most serious cancers for women. However, with the advent of pap smear, HPV vaccine, and surgeries, the disease can now be screened for and in many cases prevented. It is one of the most preventable types of cancer. Cervical cancer is most frequently diagnosed in women between the ages of 35 and 44, but it rarely affects women under age 20, and more than 15% of diagnoses are made in women older than 65. Precancerous cervical cell changes and early cancers of the cervix generally do not cause any symptoms, but there are possible symptoms which are abnormal or irregular vaginal bleeding, such as bleeding between regular menstrual periods, after sexual intercourse, after douching, after a pelvic exam, after menopause. And there are also pain during sex, vagina discharge, which is usually heavy or unusual discharge that may be watery, thick, and possibly have a foul smell. There are also other symptoms which are pelvic pain, which is not related to your menstrual cycle, increased urinary frequency, pain during urination. The most appropriate type of treatment will mainly depend on the size of the tumor and whether the cancer has spread. And also there are several treatments or therapies can be done for cervical cancers. At an early stage, a small surgical procedure might be enough. If the tumor has already spread to the surrounding tissue, surgery will be recommended to remove the entire womb. Surgery can be used as primary therapy as well as secondary therapy after another treatment has been used. So there are primary therapy, which are cone biopsy, simple hysterectomy, radical hysterectomy. Con biopsy is the removal of a wide circle of tissue that surrounds the opening of the uterus and includes the lower portion of the cervical canal. Microinvasive cancers can be treated with con biopsy, particularly if retaining fertility is an issue. On the other hand, simple hysterectomy is the surgical removal of the entire uterus, including the cervix, either through an incision in the lower abdomen or through the vagina with or without using laparoscopy. Simple hysterectomy is indicated for the treatment of early microinvasive cervical cancers in postmenopausal women and younger women who are not interested in preserving fertility. And radical hysterectomy is the most common surgery for early invasive cancers. This surgery removes tissue to the sides of the uterus and often lymph nodes in the pelvis and around the aorta. The tubes and ovaries are not routinely removed unless they appear abnormal. And there are also secondary therapy, which are salvage surgery, palliative surgery. Salvage surgery consists of radical hysterectomy, including removal of a portion of the upper vagina to decrease chances of recurrence of the cancer. This is performed when the patient has had primary surgery, but microscopic examination of the removed tissue shows that the margin of normal tissue around the cancer is too thin. This is also done when the patient has undergone radiotherapy and or chemotherapy, but early recurrences or incomplete destruction of the cancer are noted on follow-up. Palliative surgery is sometimes done in advanced cancer to relieve obstruction of the bowel or to treat fistulae. Radiotherapy might be also considered. This is still an option even if the tumor can no longer be removed through surgery. It uses sophisticated equipment to produce invisible rays that are beamed onto the cancer and the surrounding affected areas. The rays penetrate the body and destroy cancer cells so that the cancer is fully or partially eliminated. It is not painful, but it may cause significant side effects. And primary radiotherapy with or without chemotherapy is used with curative intent for women with cancer at stage IIA2 or greater. This may be offered to women with cancers greater than 4 cm in diameter, confined to the cervix, and for cancers that have spread beyond the cervix. Primary radiotherapy intended to cure earlier cancers and is provided with daily treatment for 5 to 6 weeks by using two modes of delivery such as external beam radiotherapy and internal radiotherapy. In some patients, it can be combined with chemotherapy. Chemotherapy is rarely used alone as the primary treatment for cervical cancer. It is used as primary therapy combined with radiotherapy. It is also used first in women with very large Burkitt tumors to reduce the cancer size, and then followed by radiotherapy. It is done in this sequence because cancer is shown to respond better to radiation when the tumor is less Burkitt. Palliative chemotherapy is sometimes used to relieve symptoms in women with widespread metastasis to liver, lung, and bone. The last therapy is called adjunctive therapy. It is another treatment used with the primary treatment to assist the primary treatment. For example, radiotherapy may be given as adjunctive therapy in combination with primary therapy. If the surgeon discovers that the cancer has spread beyond the cervix to the parametria or to other pelvic organs during primary surgery, or if the pathology report indicates less than 5 millimeter of disease-free tissue around the cancer after hysterectomy. And lastly, involvement of lymph nodes with cancer was found during primary surgery. There are also vaccines which can prevent cervical cancer beforehand. These vaccines aim to prevent infection from HPV type 16 and 18 since these two types are most carcinogenic and are responsible for majority of cervical cancers. And they also have long-term efficacy and safety. First vaccine is bivalent vaccine, which are Cervarix and GlaxoSmithKline Biologicals. Sustained high immunogenicity of the bivalent vaccine was demonstrated in adolescent girls aged 10 to 14 years, up to 7 years after first vaccination. Other studies of the bivalent vaccine have evaluated long-term immunogenicity in older women. In women aged 15 to 55 years, more than 99% of women remained seropositive for anti-HPV 16 and anti-HPV 18 antibodies, up to 4 years after vaccination. Second vaccine is quadrivalent vaccine, which are Gardasil and Merck. There were no cases of HPV-related precancerous cervical dysplasia or genital warts in vaccine recipients who are young women. In the population of adult women who are between 24 and 45 years old, quadrivalent vaccine's effectiveness continues to be high 6 years following vaccination. Lastly, the efficacy of quadrivalent vaccine in preventing infection and genital disease in males has been assessed in the randomized double-blind placebo-controlled trial in 4,065 healthy boys and men aged 16 to 20 years with the follow-up of 3 years. Approximately 95% of patients with stage IA cervical cancer survive without evidence of cancer recurrence 10 years after surgery or radiation therapy. Less than 5% of patients with stage IA cervical cancer experience recurrence. And small stage IB cervical cancers can be successfully cured with hysterectomy or radiation therapy in approximately 90% of patients. However, Burkitt stage IB cancers with greater than 4 centimeters in size are only cured in 70 to 75% of patients when surgery or radiation therapy is administered alone. However, cervical cancer does not get cleared completely.
We're going to talk about the social impact of cervical cancer. A social issue comes from STDs, where women who are more promiscuous are at a much higher risk of contracting STD, which eventually leads to cervical cancer. This is generally due to having many partners in a person's lifetime, which increases the risks. So not only are females responsible for this, but males can also contribute to cervical cancer, as the risk increases due to being sort of like a numbers game where the infection spreads throughout the population. Regular use of birth control pills for women also potentially increase their risks, as well as smoking for obvious reasons. These are overall basically just lifestyle choices where the disease plays a part in. So we're going to talk about the global impact that cervical cancer can have. Basically, all women are at risk, with most of this due to whether or not early screening for the disease is available. Most of this is connected to the economic impact related to the disease. Cervical cancer can also have an economic impact, as the disease is generally more often seen in uninsured and low-income communities, again, mostly due to screening. Another major contribution that cervical cancer has are the HeLa cells. These cells are basically cervical cancer cells that are immortal and are constantly replicating. They've been used in development for a variety of things, such as medicines and vaccines, the most notable one being the polio vaccine. They're also used to test other products that humans use, such as cosmetics. So there are people or entities that are responsible for being involved with funding the research on cervical cancer, as well as some other advocacy groups. So these groups include the World Health Organization, as well as the American Cancer Society, as well as many more. Merck and Company is a pharmaceutical company that manufactures Gardasil, which is a treatment for HPV. So some of the notable people in the field are Dr. Fraser and Dr. Cho, who are the two researchers that discovered Gardasil. So the people that benefit from more knowledge about cervical cancer are actually both men and women, as it can affect the livelihood of both genders. If we're talking about this in a global sense, then the South, such as Africa, Latin America, and Southeast Asia, are more likely to benefit, as they are countries that lack resources for their people to get regular screenings. Over here at home, basically women in low-income and uninsured communities are more likely at risk due to the same issues regarding poverty